Assalamu alaikum. Now I would like to discuss about vomiting during pregnancy. Okay, nausea and vomiting. Nausea and vomiting during pregnancy affects many women in the nausea and vomiting during pregnancy affects many women in the first trimester and is relatively mild with no associated weight loss, hypovolemia, and electrolyte abnormalities. What is the pharmacological treatment, first and second line, of nausea and vomiting in pregnancy? Like morning sickness, avoid triggers, consume fluid 30 minutes before and after the solid meals. Avoid triggers, consume fluid 30 minutes before and after the solid meals. First line is ginger, pyridoxine, vitamin B6. Second line, add doxylamine. Okay, some cases of nausea and vomiting during pregnancy can mask an underlying eating disorder with placental with potential concerning findings including weight loss with an already relatively low BMI, weight loss with an already relatively low BMI, unpredictable appetite suggesting dysregulated eating habit, and with skipping meals suggesting possible caloric restriction followed by episodes of overeating, and distorted view of a body weight and shape. Distorted view of body weight and shape evidenced by perception and looking pregnant despite early gestational age when the uterus is still below the pubic symphysis, and switch to maternity clothing despite weight loss, and evaluated for disordered eating behavior. So these are the concerning findings like weight loss with an already already relatively low BMI, if there is unpredictable appetite, distorted view of body weight and shape, and evidence for mm, distorted disordered eating behavior. Now, most important, hyperemesis gravidarum. Hyperemesis gravidarum. Risk factors are these three: HMH, heredity for multiple gestation, and history of hyperemesis gravidarum. If you look at the clinical feature, if we look at the clinical feature, uh, there may be severe persistent vomiting, more than 5% of the pre-pregnancy weight loss, dehydration, and orthostatic hypotension. So these are the feature like it is a diagnosis of the exclusion based on clinical presentation and the labs, and these things like weight loss more than 5% of the pre-pregnancy body weight, or more than 3 kg, weight loss more than 5% of pre-pregnancy weight loss, or more than more than 3 kg, signs of dehydration, orthostatic hypotension, tachycardia, dry mucous membrane, uh, reduced skin turgor, and the timing symptoms start in the early pregnancy, and the timing symptoms starting in early pregnancy less than 10 weeks of symptoms starts in the early pregnancy less than 10 weeks of gestation, with gradual resolution over weeks. labs in labs in labs, what you may find. Okay, in the lab it shows hypokalemic metabolic alkalosis due to vomiting of acid gastric secretion. Due to vomiting of acid gastric secretion, electrolyte abnormalities, hypokalemia, hyponatremia, and ketonuria. Hypokalemic, hypochloremic, metabolic alkalosis, electrolyte imbalance, ketonuria, increase urine specific gravity, increase urine specific gravity, and increase hematocrit, and mildly elevated ALT is more than the AST. Other life findings include elevated lipase or amylase and elevated T4 with low TSH, elevated T4 with low TSH benign transient thyrotoxicosis of the hyperemesis likely caused by HCG stimulation of TSH receptor. Imaging studies, right upper quadrant abdominal ultrasound are not required. Primarily used to evaluate for other potential causes nausea, vomiting like gallstone, not for diagnosing hyperemesis gravidarum. So if you want to diagnose hyperemesis gravidarum, you do not need mm, ultrasonogram of the whole abdomen. Okay, the differential diagnosis of the nausea and vomiting in pregnancy is broad, like GI disorder, liver disorder, GI disorder like gastroenteritis, cholecystitis, pancreatitis, bowel obstruction, and liver disorder of the pregnancy, preeclampsia, HELLP syndrome, acute fatty liver of the pregnancy. Acute fatty liver of the pregnancy can cause nausea and vomiting, but patient typically present in late second. Acute fatty liver of the pregnancy patient usually present in late second or third trimester. In addition, patients may have headache, hypertension. Okay, if we look at the treatment, admission to the hospital, antiemetic and IV fluid should be given. Initial management is fluid resuscitation, IV or paral as tolerated antiemetic. Then we should do some investigations, serum electrolyte, urine analysis for urine ketone and specific gravity, CBC, serum BUN or creatinine, liver, uh, um, liver chemistry, LTST, bilirubin, amylase, lipase, and TSH and T4. Okay, patients with hyperemesis gravidarum may develop prolonged hypoglycemia due to inadequate oral intake. These can lead to ketoacidosis and ketone on urine analysis. Ketoacidosis and ketone on urine analysis. Ketonuria suggests more severe disease and is an indication of hospital admission. With appropriate treatment, there are rarely any adverse fetal effect. So in hospitalization is recurred in persistent symptom, and if there is acid base or electrolyte abnormal bowel rest, correct hypovolemia, if needed IV fluid, typically Ringer's lactate along with thiamine is given because vitamin B1 deficiency sometimes can happen. Mm, and symptom control with antiemetic therapy, scheduled IV emetics, ondansetron dimenhydrinate as initially started until the patient is stabilized and can tolerate or can tolerate oral medication. Acid reducing agent, antacid, H2 blocker, PPI improve nausea and vomiting symptoms in patients with reflux. Pharmacotherapy should be considered an attempt to minimize potential fetal effect. Nutritional support is vitamin supplementation, vitamins B6, folate, dietary changes like small frequent meal and avoidance of nausea trigger, and ginger supplementation sometimes like ginger can be given. Okay, discharge is appropriate once metabolic abnormality have been corrected and patient is on stable on an oral antiemetic. Some patients need scheduled antiemetic therapy into the second trimester, but others can transition to taking medication as needed. Now, if we look at the questions, if we look at these questions, then we can figure it out. about hyperemesis gravidarum. Okay, if you look at this question, 20-year-old primary gravidorum emergency department evaluation for nausea and vomiting. Mm, the patient had nausea for past 2 months, but but for the past 2 weeks she has been vomiting for several times a day. Vitals are normal. There is okay. Look at the potassium is normal 3.5. Creatinine is normal. Specific gravity. Specific gravity may be slightly higher. Transvaginal ultrasound shows 9 weeks. Intrauterine pregnancy heart rate 160 per minute. So, what is the next best step in the management? So, perform oral, prescribe oral vitamin B6 and oral H1 antihistamine therapy. So, prescribe. So, if they are for treatment in nausea and vomiting, we in treat nausea and vomiting dietary change, then vitamin B6 and H1 antiemetic, vitamin B6 and H1 antihistamine. Then we can add oral dopamine and serotonin antagonists like ondansetron, ganacetron. Then we can add IV fluid or IV antiemetic. Then corticosteroid can be given and TPN or tube feeding if there is refractory. So in nausea, vomiting, in pregnancy, dietary change, then vitamin B6 and antihistamine, then oral dopamine and serotonergic antagonist. And then we can, if it is not corrected, then we can add IV fluid, IV antiemetic, corticosteroid, then we can add corticosteroid. And if it is refractory, then TPN or tube feeding should be done. TPN and tube feeding should be done. And doxylamine, succinate, and oral H1 antihistamine can be added with enhanced therapeutic effect. Okay, look at this question. In this question, 12 weeks of gestation, there is nausea, vomiting, electrolyte is normal, alphos normal, urinalysis normal. Which of the following is the best next step in the management? So in here, the most important thing in here on abdominal examination, there is right upper quadrant and mid epigastric discomfort on deep palpation. As there is right upper quadrant and mild epigastric discomfort on deep palpation, so she may have gallstone disease. So in hyperemesis gravidarum, some of the patients with hyperemesis gravidarum, if looks like it is gallstone disease, then you should do ultrasound of the right upper quadrant. So in contrast, pathologic nausea and vomiting should be suspected if symptoms develop and worsen after 20 weeks, after 10 weeks of gestation. If symptoms develop or worsen, these happens after 10 weeks of gestation, and other findings that warrant additional evaluation include acute onset severe symptoms, abdominal pain, intermittent abdominal pain, biliary colic, intermittent postprandial abdominal pain, fever, and bilious or bloody emesis. Lab may show leukocytosis, electrolyte imbalance, and elevated AST. Lab can show this. Okay, so that's why we should do ultrasound of the right upper quadrant. Okay, now look at this question. In this question, 10 weeks of gestation, pH is higher, alkalotic pH. So looks like it is metabolic alkalosis. Looks like metabolic alkalosis in AVG. In hyperemesis gravidarum, there may be hypokalemic, hypochloremic, metabolic alkalosis. So metabolic Alkalosis can happen due to vomiting of the gastric secretion. So looks like hyperemesis gravidarum. If you look at this question, 12 weeks of gestation prenatal, she has 7 weeks gestation of hyperemesis gravidarum. So hospitalized at 7-week gestation of the hyperemesis gravidarum. Now weight is 50 kg. It decreases 2 kg from the pre-pregnancy weight. If there is decreased weight loss more than 5% of the pre-pregnancy weight, 2 kg is not actually meeting the criteria. More than 3 kg should meet the criteria of hyperemesis gravidarum is causing the fetal growth restriction. So fetal growth restriction. Uh, this patient is underwent and has hyperemesis gravidarum, which is characterized by persistent nausea, vomiting that can extend past the first trimester. Although pathophysiology hyperemesis gravidarum itself does not affect the fetus, mothers with hyperemesis gravidarum frequently have inadequate gestational. It actually does not cause the fetus to decrease growth restriction, but hyperemesis gravidarum frequently have inadequate gestational weight gain and low pregnancy BMI and poor nutrient intake during pregnancy increase the risk of fetal growth restriction, low BMI and preterm delivery. If we look at this final question, in this question 8 weeks of again gestation, persistent nausea and vomiting, epigastric dizziness, she cannot tolerate oral intake. Okay, current weight, a 2 kg weight decrease of the pre-pregnancy, abdominal tenderness. Okay, ultrasound confirms 8 weeks intrauterine gestation and fetal heartbeat. Which of the following is the best next step? So looks like hyperemesis gravidarum. In hyperemesis gravidarum there is ketonuria, so urine analysis for ketone should be done. So that's all about hyperemesis gravidarum. It's a very important topics of the upcoming exam. Hope you enjoyed. If you like my video, please give comment and share.